Here is our zero fluff syllabus for today. 1. Study design categories. 2. Basic statistical principles. 3. Estimating risk and accuracy. 4. Evaluating study quality. And 5. Clinical practice guidelines.
Starting right off with Section 1, Study Design Categories. When you're looking at the whole research landscape, the very first split you hit is based entirely on the aims of the inquiry. We're talking observational studies on one branch, experimental studies on the other. This single distinction is huge because it literally dictates exactly what clinical conclusions we're allowed to draw from the data. Let's establish the hard line between these two. In observational studies, researchers are essentially just doing surveillance. They do not assign participants to treatment groups. And here's the crucial point you have to remember. Observational studies can only determine associations. They absolutely cannot, under any circumstances, establish causation. Experimental studies, on the flip side, are where investigators actively assign participants to treatment and non-treatment groups. And it's because of that active assignment that a properly crafted experimental study actually can establish a causal relationship. Let's punch through the keywords for the main observational designs. Case control studies. They group patients based on the presence or absence of the outcome first. That makes them perfect for quickly investigating rare diseases. Cohort studies flip that around. They group individuals based on exposure and then follow them over time to document the incidence of a disease. Cross-sectional studies take a single snapshot in time, measuring exposure and outcomes simultaneously. Finally, a case series just looks at a small group to document a disease's natural course. Those are primarily for hypothesis generating. Moving over to experimental designs, the randomized controlled trial, or RCT, is the undisputed gold standard here. Why? Because it uses random allocation to evenly distribute patient covariates, and it utilizes blinding to conceal who actually gets the treatment. If you skip that randomization step, you've got yourself a quasi-experimental study. Now, how do we appraise mountains of these studies? You've got to know the strict difference here. A systematic review is a qualitative literature review trying to find consensus. A meta-analysis is a quantitative, pooled statistical analysis of those results. Moving right along to Section 2, Basic Statistical Principles. You have to know these three definitions cold. The null hypothesis, or H0, is the baseline premise that there is absolutely zero difference between the control and treatment groups. Usually the goal is to reject it. The p-value is the probability of rejecting that null hypothesis when it's actually in fact true. A p-value of less than 0.05 is generally what we call statistically significant. And that 95% confidence interval, that means if we repeated the study into infinity, the true value would fall within that range 95% of the time. It indicates the precision of our measure. Choosing the right analytical test depends entirely on your data. If you're comparing a continuous, normally distributed variable between exactly two groups, like length of stay after a lap versus open colectomy, you use a t-test. If you add a third group, like robotic colectomy, you have to step up to an ANOVA. The chi-square test is your standard for categorical data and contingency tables. And if you're measuring time to event data, like survival rates until death or recurrence, you're going to need Kaplan-Meier curves or Cox proportional hazards models. Section 3. Estimating risk and accuracy. There's a critical difference between these two metrics. Prevalence is a static snapshot. It's the proportion of individuals in a population with a disease at one specific point in time. Incidence, however, is a measurement over a duration. It tracks the number of brand new cases developing in a population over a discrete period of time. The standard 2x2 contingency table is how you're going to map out nearly every single risk calculation. It strictly organizes your data by outcome, meaning disease or no disease across the top columns and exposure status down the rows. So box A represents individuals who are exposed and have the disease, box B is exposed but without disease, and so forth. From that 2x2 table, we can estimate association. Relative risk is utilized specifically for cohort studies. It calculates the incidence of disease in the exposed population versus the unexposed population. The odds ratio is tailored for case control studies. It compares the odds that a case was exposed versus the odds that a control was exposed. Now, for both of these metrics, a value exactly equal to 1 means there is zero difference in risk. A value greater than 1 means a higher risk or likelihood for the exposed group. Let's blast through diagnostic accuracy. Sensitivity is your true positive rate. It's the test ability to correctly identify those who actually have the disease. Specificity is the true negative rate, correctly identifying those without the disease. Positive predictive value, or PPV, looks at it from the test's perspective. It's the probability that you actually have the disease given a positive test result. Now, here is a massive takeaway you must remember for the exam. Predictive values, like PPV and NPV, change significantly depending on the prevalence of the disease in your population. But sensitivity and specificity, they do not. They remain constant, completely regardless of prevalence.
All right, Section 4, Evaluating Study Quality.
Assessing internal validity really comes down to error and power. Power is your ability to correctly reject a false null hypothesis. Essentially, it's your ability to detect a true difference when one actually exists. A type 1 error, represented by alpha, is a false positive. You falsely rejected the null hypothesis. A type 2 error, represented by beta, is a false negative. You completely missed a true difference. Remember this relationship. As type 1 error decreases, type 2 error increases. To minimize both types of errors simultaneously, you literally just have to increase your sample size.
Now for a rapid-fire rundown of the biases that can compromise your data. Selection bias happens when participants systematically differ from non-participants. Measurement bias is an error in exactly how exposure or outcome is recorded. Recall bias hits when participants just remember past events inaccurately. Interviewer bias happens when an unblinded researcher frames questions differently. Then there's the classic Hawthorne effect. Individuals change their behaviors simply because they know they're being observed. Attrition bias is the systematic loss of patients to follow-up. And lead time bias happens when early detection, like from a fancy new screening tool, falsely makes it look like survival time is lengthened. Finally, always watch out for confounding variables. These are those sneaky covariables associated with both the exposure and the outcome that'll drive a false relationship if you don't address them statistically. And our final section, Section 5, Clinical Practice Guidelines.
The widely accepted USPSTF classification system shows us exactly how the quality of evidence perfectly aligns with practice guidelines. Level I evidence, which comes from systematic reviews of randomized controlled trials, drives Grade A recommendations. A Grade A means there's high certainty that the net benefit is substantial. And the clinical mandate there? You absolutely offer or provide this service to your patients. Quality data drives quality care.
Let's wrap this explainer up by seeing how this builds into active clinical application. We're going to end with a direct test of your active recall, using a scenario straight from the textbook. A new lung cancer test identifies 125 true positives out of 150 total patients with the disease. It also identifies 20 false positives, which leaves 280 true negatives out of 300 total patients without the disease. So what is the sensitivity and specificity? Think back to our formulas from the 2x2 table. Sensitivity is true positives divided by the total with the disease. That's 125 over 150, which gives you 83%. Specificity is true negatives divided by the total without the disease. That's 280 over 300, which equals 93%. Getting comfortable doing this math under pressure is vital. But I want to leave you with this. Next time you are handed a groundbreaking surgical paper advocating for some radical new technique, are you going to blindly trust the abstract, or will you interrogate their 2x2 table to find the truth? Because out there on the wards, that difference could literally save your patient's life.